So good evening, everyone. Today we have a national faculty with us to speak us on hiatus hernia, Dr. Patankar sir. So in November 2019, he had come to us in Nagpur and he taught us how to operate hiatus hernia. Today he is going one step ahead. So if while operating, if we get in some trouble, how to get out of those troubles, he is going to speak us on that, and he is going to share his knowledge on that. For this talk, we have our panelist, Dr. Rahate sir, online already, and Dr. Gajbia sir. Gajbia sir will be joining us a bit late. He is in some emergency. So I'll ask Rahate sir to just introduce about the topic and the speaker, and then we'll go online. Rahate sir.
Thanks Yogesh, and thanks Dr. Roy for joining us. We have this CME, this is the 13th day today, and lot of interest is being created, and today I think since Dr. Roy is there, we will be having a feast today. He needs no introduction. He is almost like a Nagpurian. He has come empty time to Nagpur, and we have seen him operating and talking not many times on this hiatus hernia. But I requested him for a different hiatus hernia today, and I think everybody are eager to hear him and see him today. Please, Dr. Roy, please go ahead.
Thank you, Prashant. Yogesh, I'm clear to everyone.
Sir,
audio and video.
Yeah, we have 27 people online. We are seeing you. We are listening to your talk voice clearly, and the presentation is also clear. You can start.
Wonderful. Thank you, Yogesh. I think even for a simplistic man like me, you have done a wonderful job bringing me online, and I compliment Prashant and VSA for this wonderful initiative. Prashant एक बड़ा चालाक आदमी है. Seeing the kind of complications that I create in my surgery, he said, "आप सर routine hiatus पे मत बात करो, आप complication पे बात करो. Complications में आपका बहुत experience है. आप create भी करते हैं और ऐसे निकलते भी हैं." So I think ये प्रशांत का double word है. I have to acknowledge a very smart gesture by Prashant. I also don't think I have a national faculty. I am very much a Nagpurian. I think my wife is convinced I have a girlfriend in Nagpur. The number of times I go there. But I'm still waiting for Prashant to invite me to his house in Bangkok, which he hasn't done after promising me many times. What I'm going to do in the next 20-30 minutes is going to tell you about the problems that I have faced doing anti-reflux surgery, how I got into trouble, how I got out of trouble, and what lessons I have learned over time. We have now done just over 1,000 hiatal hernia surgeries, and I've done about 70 redo hiatus hernia surgeries. I will show you some videos of my own mistakes and other people's mistakes. Obviously, the surgeon's name is going to be hidden in this, but I'll start by showing you what is called, the American Psychological Association calls it Dunning-Kruger effect. My first hiatal hernia surgery was in 1995, exactly 25 years ago. When you start doing a complex surgery, you finish about 5 or 6 cases, and you think, boss, ye to mere ko aata hai, ye to easy hai. Then about 6th or 7th patient gets some dysphagia, and then you think, man, there is more to it than I thought. Another 10-15 surgeries down the road, another patient gets some problem, and you think, I'm never going to understand this. And after you complete about 200 surgeries, you realize there is more to surgery than simply wrapping the stomach around the esophagus. And I think there is as much to learn from problems as there is from doing new things. So my talk, as per Prashant's suggestion, is unhappy patients after fundoplication. And I think fundoplication is now being done in the nook and corner of our country. So like we saw a run of complications when lap poly came in, we are seeing a run of problems come after anti-reflux surgery, because this surgery, I believe, is not too well taught. If we look at literature, this is a paper in Surgical Endoscopy in May of 2019, a fairly recent paper. It says that 2 to 30% of our patients who you operate will have some kind of failure. Either about 3 to 4% will need a redo surgery, or they will be back on proton pump blockers. The same paper dissected these symptoms, and most surprisingly and worryingly, 59% of patients develop new symptoms that they didn't have preoperatively. This is a paper in British Journal of Surgery in 2018. So dysphagia, choking, epigastric pain, gas bloat, which were not there pre-op, develop in more than half patients. 22% of patients have recurrent symptoms, the same ones that they had before, that is heartburn, regurgitation, dysphagia, epigastric pain. So if you look at a cohort of say 100 patients, this is the kind of distribution you are going to get. The first thing, I get a lot of references now from across the country for patients with failed surgery or redo symptoms. And the first thing when I kind of analyze them in the OPD is, are these refractory symptoms or is this refractory GERD? Is it really a failure of surgery or is it something else? And this is a paper I would like you to read in, it was the Asia Pacific Consensus on Refractory GERD published in GUT of 2016. So we need to analyze, are these new symptoms and what we have in our OPD is a questionnaire. We asked them what symptoms they had pre-op, and we asked them what new symptoms they have got or what symptoms were persistent, and we have some learnings from how to avoid them and how to treat them. I'm not going to talk to you about routine fundo, but a quick word about these 4 types of operations that we do for reflux: Nissens, Toupes, colysis, and DOR. The DOR fundoplication clearly is a weak anti-reflux operation, and we do it only along with the Hellers as a preventive mechanism. I have only done 2 colysis gastroplasties in last 25 years, and I'll try and show you some videos of them. The Nissen and Toupes is something we'll discuss. There's a beautiful saying by Thomas Huxley: the greatest tragedy of science is the slaying of a beautiful hypothesis by an ugly fact. So this is extremely relevant to anti-reflux surgery. We are offering a surgery for what is essentially a lifestyle illness. I'm always happier to do a gastrectomy or esophagectomy because a patient is often willing to accept bile gastritis or reflux because he only wants 2 things. He wants his symptoms to go and he wants to live. He doesn't want a recurrence. When you do a sleeve gastrectomy or a gastric bypass or anti-reflux surgery, you're effectively treating patients for what is a lifestyle data. So this is extremely important to choose your patients very carefully. I want to point out a beautiful book called Checklist Manifesto by Atul Gawande, an Indian-American author. And this is a beautiful book that all of you should read. And I actually try and break down my operation, any operation, be it a anterior resection or a fundoplication, into 10 steps. And this is the SOP. So what is a failure? I'm looking at this very closely now. What do you call a failure of an anti-reflux operation? Either a patient has recurrence of the same symptoms he has, or he has developed new foregut symptoms like gas bloat or dysphagia. And this could either be classified as an anatomical failure or a clinical failure. So this is the data from the same paper published in Surgical Endoscopy. So why are you likely to get a failure? Either your choice of patient is bad. The patient along with GERD also had IBS or diverticulitis or some psychosomatic problems. You haven't done a manometry pre-op, so you've done the wrong procedure for the patient. Like for example, a patient with a poor esophageal motility, you've done a Nissen's wrap. And these are patients who are prone to getting dysphagia after anti-reflux surgery. Technical failures are actually mistakes that you make. And believe me, out of the 70 odd cases I've done, technical failures were just seen in 3 or 4 patients where the wrap was done on the stomach itself. And I'll show you videos of those. Majority of times, I think almost 30 to 40% is inappropriate patients taken for surgery, and in 60% of patients, the wrong procedure done for the patient. Wrong indication. Mandatory in my book to do a manometry pre-op. Never ever operate a patient without that. The 24-hour pH is, I would say, not mandatory. I would do it only when the diagnosis of GERD is in doubt. The LES pressures are very important. If your LES pressures are normotensive, that is, your LES pressure is either normotensive or hypertensive, even if the patient has typical GERD symptoms, it is a red flag sign. Your antennae should be up. There is something wrong with this. Why is a normotensive patient getting reflux-like symptoms? Am I audible, Prashant? Yogesh?
Yes, sir,
Prashant?
you are audible. Yes, sir, you are clear
Great.
and audible,
Great.
sir. Go ahead. Go ahead.
Wonderful. So let's look at which patients, let's look at literature first. Before I tell you my own experience, Let me tell you which patients based on literature, and this is a paper in the ANZ Journal of Surgery in 2002. So the male patients, those who respond to proton pump blockers, those who have normal body motility are your best candidates. Those who have atypical symptoms, and what do I mean by that? Chest pain, laryngitis, jaw pain. Those who have abnormalities of the esophageal body motility on a manometry are patients you should be careful of. So this is how I teach my fellows how you must, in your mind, look at patients who come to you. So the best patient is a young patient. He is a volume refluxer. What do you mean by volume refluxer? त्या तोंडात पाणी येतं किंवा खाल्लेलं अन्न उलट येतं. नुसती जळजळ होणारा पेशंट हा ऍसिड रिफ्लक्सर आहे. इट इज heartburn, and this could also be seen in motility disorders or achalasia. So be careful of the acid refluxers. I'm always happy to treat a young male volume refluxer who is responding to PPI. There are a small subgroup of patients who are PPI non-responsive, who also I will offer surgery to, but that's the topic for another lecture. This is the kind of workup that we do. Before advising anti-reflux surgery, make sure they have no lower GI symptoms. Many times patient of IBS or functional bowel disease also get some GERD-like symptoms. Please do not operate on them. They will bug your brains post-operatively. If any of your patient complains of upper abdominal bloating pre-operatively, we routinely do a gastric emptying, and the gastric emptying study has to be done on 2 days, 1 day with liquids and 1 day with solids, and we can predict which patients will get gas bloat post-operatively. So these are some of the patterns of failure I've got, and I will show you photographs and videos of all my patients through all of this. So the next 10 slides will be all these things that I'm putting up for you. The most important thing is inadequate mobilization of the esophagus. If you ask me if there is single common cause of failure, it is people who don't dissect into the posterior mediastinum adequately to get 5 centimeter length of esophagus. Number 2, preserving the vagus. Now I can tell you I have divided the vagus 3 times. In 2 patients, it was posterior vagus only, and 1 patient was anterior, and all these were recurrent hiatal hernia surgery. And none of the patients actually had a gastric motility issue post-op. The only problem I've seen with a gastric motility issue was a large type 3 paraesophageal hernia with the stomach was in the chest for several weeks. I had preserved the vega in that patient, and that patient had a lot of gastric motility issues and required TPN for almost 2 weeks. What about the crura? The SAGES guideline mentioned it's a type A recommendation that you must do a cruroplasty, but how much is enough? In the early part of my practice, I was tightening the crura too much, closing it very hard. Even 5, 6, 7 centimeter defects I was closing under tension, and that was an important cause of failure. Remember, there is enough data that if your intercrural distance is more than 5 centimeters, please be careful. The third is short gastric division. The early part of my career till about 2004, 2005, I did not divide short gastrics. Then I started doing selectively, and since 2008, I divide short gastrics in all patients. There are several mistakes you can make with wraps, and I'll show you some videos of this as I go on. The first is what I mean. This is an older video of mine from 2006. You can see I'm using a 10 millimeter harmonic, but look at how much of mobilization of the stomach I do. My left hand pulls on the stomach, and you can see the Foley's catheter is marking the OG junction. The pancreas is open for you. I'm pulling the stomach with my left hand and dividing the entire bare area of the stomach and the entire short gastrics. When I say I will do a full and floppy Nissen, this is what I mean by a full and floppy Nissen. And in the last maybe 200-300 cases, I cannot recall a single patient where I didn't divide the short gastrics or didn't do this mobilization like I'm showing you in these patients. Even in the fattest person, you know, it is not just dividing 3 short gastric vessels. There is a lot of loose areolar tissue. Basically, when you pull on the left side, the left crust must be open from this side. That is the end point of my dissection. Remember, the last short gastric is the one that you need to be careful of. This is usually a short vessel that enters the splenic vessels and has a tendency to bleed. So please be careful of the last one. The video on the right is a patient I got referred from a South Mumbai hospital. He had a fundoplication done apparently uneventfully, discharged in 48 hours. and came to me on day 5 with a perforative peritonitis, massive gash on the diaphragm in septic shock. So put a scope in, looking to give a wash, trying to find out what happened in this, and you can see a nice, clean, punched out perforation. This is in the gastric wrap that is brought out from the patient's right. You can see the extent of contamination. So why is this not an accidental injury to the stomach? Because there is no pouting of the mucosa. This is a thermal burn. And what's happened is the surgeon has gone in too close to the greater curve, like you would do for a sleeve gastrectomy, and landed up burning the greater curve of the stomach, causing this kind of thermal injury. So remember, any tool you have, you see the hole that I'm seeing with this graph. What I did for this patient was suture this close and then do a feeding jejunostomy for this man. So whatever tool you use, remember protein denaturation is occurring at 60 degrees Celsius. If you go too close to the greater curve, you're going to get burns and you're going to let her in trouble. Does division of short gastric cause gas bloat? I am not sure. I personally have been dividing the short gastrics at least in the last 300 fundoplications, and you rarely see any gas bloat post-op. This is some of the data. I have found 4 large studies on division of short gastrics, and there is no clear data that ever shows the division of short gastrics is the cause of gas bloat. The second kind of patients who come to you are those patients who come with dysphagia, having had their anti-reflux surgery done elsewhere. How do you approach a patient who comes to you with a post-op dysphagia? The first question I ask him is, did you have any dysphagia or chest pain pre-op? Number 2, did you have interscapular pain pre-op? These are indications of motility disorders of the esophagus. Do you have joint pains? Do you have rashes? Do you have family history of collagen vascular disorders? The next question is, did this dysphagia start immediately after surgery or it came 6 months later? Extremely important history. If the patient had no dysphagia pre-op and the dysphagia came immediately post-op, likely this is a technical issue. Unfortunately, in our country, the surgeons don't give people very detailed notes or pictures. But here it is important to see how big the window was, how tight the integral closure was, and what kind of wrap was done. On the other hand, a patient who tells me that, doc, I was well for a year and a half, and then I developed dysphagia. So this is likely to be a wrap migration, and that needs a different kind of workup. What am I going to do? I'm first going to do an esophageal manometry, look at the body motility and to look for motility disorders. Number 2, I'm going to do a CT scan with oral and IV contact. Obviously, a gastroscopy was done earlier. So followed by a manometry and a CT scan that we did. Now look at this video. I'm showing you what we currently do. We use a Fogarty's catheter, and after doing a crural closure, we leave enough space for an 8 French Fogarty's balloon to be expanded. In the year 2011, I saw one of my anesthetists putting in an esophageal bougie and rupturing the esophagus. Never allowed anyone to put that down. You may use a gastric calibration tube, but easier just to use a simple Fogarty's catheter inside. So if you look through the causes of dysphagia, number 1 is wrong selection. Number 2 is your lending wasn't good. Number 3, your crural closure was too tight. Number 4, your window was not large enough. Number 5, your fundus is not well mobilized. It's pulling the wrap to the other side. It is what is called a torsional deformity of the esophagus. Or number 6, your wrap is done wrong. So this is what a good window should look like. This is you can use a Foley's, you can use anything to hook up the esophagus. You see the right crust. Another little technical tip: never remove the peritoneum on the right crust. If you remove the peritoneum on the right crust, you take deep sutures. Once in a while, the whole right crust will split in front of your eyes, and then you have a problem. Remember when you did your first house post, your first few Bessanies, and you used to take deep, tight sutures of conjoint tendon, and on table the conjoint tendon will split. Similarly, the right crust can split. So you want a large window, you want to see the posterior vagus, and you want to leave the peritoneum intact on this. The next problem that I'm going to talk about is wrap migration. So what does wrap migration mean? The 2 things can happen. If your esophagus is shortened, the esophagus with the wrap will go into the chest. Option 2, what may happen is the esophagus may be okay, but only the wrap will migrate upstairs into the posterior mediastinum. So some of the tips here is make a large window, anchor the wrap to the esophagus. You're doing a Nissen's, take 1 bite or 2 bites through the esophagus, and lastly anchor the wrap to the crura. I'll show you this. Now this is one of my own patients. You can see it's an older patient because I've used Mercit and a Prolene stitch which I haven't used for a while. You can see that the wrap is twisted. A completed wrap like you see on the right hand side should be dead center, and you should see about 3 centimeters of intra-abdominal length of esophagus above the wrap. So what I did, what is happening in the picture on the left hand side is there is something pulling on the greater curve because I have not mobilized the greater curve well enough. What you need to do in this situation is undo the wrap, take the wrap back to the left side, mobilize it a little more, and I did that and I got the right hand side picture of the same patient. Now, if you look at the picture on the right hand side, this is what you want to do. The common mistake you do is you wrap the stomach on the stomach, like you see in the bottom picture. And this is what we call hourglass deformity after fundoplication. It is like doing a small gastric pouch. It is like putting a band around the stomach for a bariatric surgery. And the symptoms are vomiting, chest pain, and weight loss. And for that, nothing works except undoing the wrap. I'm not going to run all my videos. The video on the top shows you a wrap migration. The video at the bottom is a little interesting video which I'm going to show you. This is a patient who came to me from Pune. You can see I'm mobilizing the wrap. It's important to create a window between the wrap and the esophagus. I see a very large vessel which is crossing the gastrohepatic omentum. This may be sometimes an anomalous left hepatic that comes off the celiac. So my strategy here is to put a clip on that vessel and wait for 5 minutes to see if the left lobe of the liver gets congested. I don't divide it immediately. In the meantime, I'm mobilizing the wrap from the left cruise, which has been closed. You can see you use any energy source you like. This has to be done painstakingly. You don't want to injure the esophagus and you don't want to injure the stomach. After a few minutes, I have seen the left lobe of the liver, and I'm convinced that there is nothing wrong with the left lobe of the liver. I'm safe to divide it. So I'm doing this. Basic idea is to restore the esophagus back to its normal virgin self. So at this point in time, I've seen I'm putting one more clip and then I'm dividing this. The second stage is to divide the wrap. You must never use a wrap that was done before. Create a window between the wrap and the esophagus, like I'm done here, and then you divide the wrap. You can either do it with a sharp scissor, or if the wrap is very tightly adherent, you may use an echelon flex and divide the wrap using a cartridge. Both are possible. I usually land up using echelon flex in most of my patients. So here I'm dividing the vessel crossing the hepatic omentum, confirming it is not an aberrant left hepatic artery, and then you must restore the anatomy back to normal. For this, you need to do extensive esophageal lengthening. You can see the closed crus. You see, most of these patients don't have a problem in crural closure. I'm now trying to make a window behind the esophagus because clearly I need to lengthen the esophagus more. You see how I'm dissecting into the chest? And this is all virgin planes. I'm using now echelon flex to divide the wrap, and then I mobilize into the chest, and you can see how virgin these areas are, indicating that there has hardly been any dissection into the chest. So important cause of failure. Some other causes of failure. Look at the picture on the top left. This is a recurrent hernia. The one on the right is where the whole wrap with the esophagus has migrated upstairs. Like I told you, 2 ways. If you have a shortened esophagus, the wrap with the esophagus will go up. And the other option is the esophagus will remain okay, but the wrap will move. And this is the barium scene of the same patients and the endoscopy scene of the same patients. Now, this is the bottom right video that I'm paying is a patient who came to us in Surat. He came to us 1.5 months after surgery. The history was he had a stormy post-operative course, had an ICD placed post-op. I suspect he had a gastric abscess after the wrap migration. You can see I'm going through the diaphragm. The wrap is tightly adherent to the lower lobe of the left lung. I'm unable to dissect and separate this completely, as you can see here. This is probably the only patient that I did a left thoracoscopy, put a scope in the left chest, did a sharp dissection, as you can see me doing now, to separate the lung from the stomach, as you see me doing here. And then only I was able to bring the stomach down. And this is probably one of the few patients I did a cholecyst gastroplasty, because try as much to mobilize. You see what's happening? I'm pulling the wrap downwards and it's bringing back into the chest. It's formed adhesion in the chest. And the esophagus is shortened because of fibrosis. So I divided the short gastrics, mobilized as much as I could, and yet I didn't get a good distance. I did have to do a cholecyst gastroplasty. I'll show you this video when we're discussing short esophagus. The picture on the bottom left is the same patient 6 weeks afterwards. When I did an endoscopy, you can see a beautiful whorl, and that is the fundoplication that I had created for him. And this is a patient actually I had seen during Amasicon when I had come there. It is a patient operated in a hospital in Nagpur, and you can see a pseudo-achalasia. You can see a beautiful wrap, and there is a pseudo-achalasia. As you can see, there is barium getting held up in the lower end of the esophagus. This patient came to me in Mumbai. We undid the wrap and redid the wrap. This is extensively tight wrap and a tight crural closure. Look at the endoscopy picture on the right hand. Apologies because I have not hidden the name of the patient in this one. This is a typical wrap migration because of a improperly done wrap and a shortened esophagus. So this patient will present with severe interscapular pain, severe retrosternal pain, and severe vomiting. What you should do for this patient is a CT scan and then take them back to theater. So this is one of the techniques that I want to emphasize is how to prevent wrap migration. After completing the wrap, I will take one stitch between the wrap to the completed crural stitch, and this is a way of preventing wrap migration. So I'm not going to play all my videos for you, but these are multiple cases. I'll show you another of my own mistakes. This video that I'm showing you, I think I did in 2007 or 2008. It is a physio mesh I'm using for a recurrent hiatus hernia. And the mistake I've made is it's a very wide crural defect, about 6.5 centimeters wide. We actually measure this with a tape. In those days, I was not doing meshes routinely. I have put a physio mesh on the defect, and then I'm doing a wrap, and I thought this patient had done well post-op. The patient had no symptoms for 3 years. In 2012, he joined Siemens, had a pre-employment checkup, and a small gastric bubble was seen in the chest. So although he had no reflux symptoms, it was what we call a radiological recurrence. And the mistake here is I should have taken a darning stitch between the crura, and we always now do a onlay or a bridging repair. What is a bad word in ventral hernia is a good word in hiatal hernia surgery. The right side video which I am playing for you is a patient who came to me from Goa, and you can see this is an old video because what this surgeon has done is he has placed a mesh anterior to the esophagus. Now meshes will always be placed posterior to esophagus. However well this surgeon has done deploying a mesh anteriorly, it will always fail. Later on, I will show you a video how this mesh was taken out and how we handle this patient. These are two different patients which I am going to show you, both with recurrent hiatal hernia. But you can see in this patient, I was not even able to find the esophagus after half an hour of dissection. And I actually did an intra-op endoscopy, which you'll see me doing in a minute. See how densely it is adherent to the left lobe of the liver. I've actually made a chemo of the left lobe of the liver just to find the esophagus. I'm still after 1 hour not clear, and at this point I give up. I do an intra-op endoscopy, find the esophagus, and then continue the operation. Remember, I'm okay to injuring the wrap, but never injure the esophagus. The morbidity is too much. This is a patient who had an open fundoplication done in a teaching hospital in Mumbai. So this can be a very troublesome operation. Please be careful doing this. Now these are various patients of mine which I have done redo surgeries just to show you what can be done and what kind of trouble you may have doing this. But if you ask me, the most difficult part of this operation is to reduce the stomach back in the abdomen. Because usually the patient comes to 2, 3, 4 months after surgery, after recurrence, and by that time the wrap has actually formed adhesion in the chest. Having said that, only in one patient I have put a scope in the left chest and done a thoraco-laparoscopic reduction, which I showed you earlier. So this adhesion in the chest and reduction of the stomach and lengthening of the esophagus probably to me is the most difficult part of this operation. So I'll keep my video short because this is a patient who came to me from Pune. Came with dysphagia post-op, doing an endoscopy. As the scope goes down to the OG junction, everything looks okay, lax junction, and suddenly I see a piece of proline mesh. The mesh is actually come into the gastroesophageal junction and eroding into the stomach. So this is the same patient mesh after I took it out. Sorry, I'll just show you the mesh again. The picture on the right hand side. So never ever deploy a polypropylene or a polyester mesh at the CO junction. It is a sin. Even if you put a composite mesh, there is a small chance of mesh erosion. I actually had to do an esophagectomy on this patient. The patient had a spiking fever, he had a perigastric abscess, he was in systemic sepsis, and we did an esophagectomy, transhiatal esophagectomy, just to get this mesh out. So disaster. One of the last things I'm going to talk about is a short esophagus. And as to quote Albert Einstein, the important thing in life is to never stop questioning. Never think that I have done 5,000 gallbladders and I know it all. That's the 5,000 first gallbladder, the one where you will have a CVD injury. So never question yourself. So what is a short esophagus? Now this is also a condition that we don't talk about much in conferences. People say what cholecyst gastroplasty, what mobilizes the chest. But as you start doing two patients, you'll realize that short esophagus can be a problem and needs to be tackled. So what is the definition? So any GE junction that cannot be surgically mobilized to more than 2.5 centimeters below the hiatus without tension is a short esophagus. What we do is we loop to GE junction and pull it down. So if you're looping in tension, you must get 5 centimeters of esophagus below the diaphragm. If you're not pulling on that, 2.5 centimeters. So a lot of data, this was at the American College of Gastroenterology in October 18. I don't want to sort of go into too much of this, but a lot of data now coming out that the shortened esophagus is probably the single most important cause of recurrence. So when do you suspect a patient may have a esophageal shortening? And you should call a senior surgeon from your city and be prepared to do gastroplasty. I still maintain that I have done a cholecyst only 2 times in more than 1,000 procedures in 25 years of doing this operation. If a patient gives you a history of a benign esophageal stricture, which has been dilated or which has had a steroid injection, a patient who has a large paraesophageal hernia, and when you're doing a redo anti-reflux surgery is the time to be prepared to do a cholecyst. And this is there is a beautiful paper on this called Oschlager. I would recommend all of you to read 2 papers of his. One is 2011 and 2018, both in the Annals of Surgery, looking exactly at the use of mesh at the hiatus and mobilization. So what he recommends in this paper is you will routinely do a type 1 dissection. You divide the phrenoesophageal ligament and you should get 3 centimeters without tension. If you're not getting it, and this he says is 7% of patients, but in my case it is 100% patients. I will in 100% of my patients the last several years, I dissect into the posterior mediastinum and I will always get 3 centimeters without tension and 5 centimeters when I'm pulling on the esophagus. Only in those rare patients when you can't get that, you need to do a cholecyst gastroplasty. Now this is a conventional cholecyst gastroplasty, and this what we do is the way of doing a little trick is don't do this kind of operation, because to get your stapler down parallel to the OG junction is quite difficult because the angle of the stapler doesn't come. Instead, what you should do is place a 12mm port in the left upper quadrant in the mid clavicle line and then resect a part of fundus. You do a part of fundectomy and create a 2 centimeter length of neoesophagus. The second important point is the wrap must be done around the neoesophagus so that you have intra-abdominal length of normal esophagus above that. Point number 3, when you do a cholecyst gastroplasty, please do a short wrap. Remember, the neoesophagus of 2 centimeters is part of stomach. It is not esophagus. It does not have a normal motility. So never do a wrap of more than 2 centimeters when you're doing a cholecyst, and usually do only a partial wrap. I think already half an hour has passed. I'm not going to show you all the videos. I'll show you one of my own videos. The video is a IRCAD video. But this is, again, what I'm doing is I'm taking it down. But you can see in all these patients, this is a patient who actually had a paraesophageal hernia. You can see the amount, the sac in the chest. This is the difficult one that has to be done. So ladies and gentlemen, it's very easy to pull out somebody's gallbladder, remove a kidney, remove a spleen. But when you do a functional operation like a pyeloplasty or a anti-reflux surgery or a gastric bypass, probably these are operations where you need to think about what you're doing. You need to analyze the patient's symptoms, and only then you are able to do the right operation for the right patient. This, I think, is very important. This is a new device I saw in the US 3 months ago when I was there with Dr. Demista. What they do is something called an endoflip. The endoflip is a device which is placed either preoperatively or intraoperatively. I saw Demista using this intraoperatively. He did the wrap, and what this does is this machine actually measures the distensibility of the esophagogastric junction. So you can almost be certain that you will never get a post-op dysphagia because of a tight wrap. You can also use it in operations like a Heller's myotomy, because if you leave any inadequate myotomy, the endoflip shows that the distensibility is not complete. So this, I'm sure, will be launched in India in the next few years. Now this is something that I teach my fellows. Does every person who has a failed anti-reflux surgery require a redo? Answer is no, because redo has better after the wrap. When you analyze the CT and everything else, it is a good wrap. And the pH data is showing Demista instead of 13.3 or 18. Don't operate on this patient, because let the patient be actually symptomatic. Dr. Ban? Hello?
Yes, sir. We are listening.
I'm getting a message saying slow network connection, turn off webcams.
Yeah.
Shall I, or just
Yeah,
continue like this?
We had just this last slide, we had a bit of hitch because of your voice. We can switch off your
Okay, are you
webcam,
seeing it
sir,
now?
if we, yeah. Now you can
Is
speak,
it okay
sir.
now?
Yeah. Please go ahead.
On the other hand, you may even have an elderly person who was well for 6 years. So post anti-reflux surgery, he was asymptomatic. Now he's got a recurrent hiatal symptoms, and the wrap is migrated or undone. So these are patients you should operate. So just because anatomically or on CT scan you demonstrate a recurrence, this is another paper I'd like you to read in Surgical Endoscopy in 2019. So when you have a symptomatic failure, first you will do a upper GI endoscopy and a manometry. You see a non-reconstructible deformity, or a patient who is remember, a person who is morbidly obese must never have anti-reflux surgery. The treatment of choice is take down the fundoplication and convert him to a formal Roux-en-Y gastrojejunostomy. Remember this important rule. So that was the paper from Surgical Endoscopy. This is what I actually follow. If a patient has a prior anti-reflux surgery, I will do upper GI endoscopy, barium swallow, CT scan. If it is normal, I will do a pH study, and I usually will leave the patient alone. I'll put them on PPI, send them to a gastroenterologist, send them to psychiatrist, but away from me. If on my imaging, I'm seeing an anatomical problem which is correlating with the patient's symptoms. For example, you have a dysphagia and you see a tight wrap, or you see a dysphagia with a tight, like the video, the barium I showed you with the pseudoachalasia. Those are patients where there is an obvious anatomical problem, and an anti-reflux surgery done again will do well. This is another beautiful paper in the American Journal of Surgery. This is a group from John Hunter. They have done up to 4 times redo fundoplication. I am amazed at these. I have only done 2 patients where I have done the 3rd surgery. All my other 70 patients were the first time redo. And this still people were able to give almost 90% improvement in quality of life and 90% success at 2 years. If you look at the various data coming on revisional surgery, it takes a longer time. There is a higher conversion rate. There are higher complication rate, and the worrisome complication is an esophageal injury. Pneumothorax doesn't worry me. Like I said, if you go back to the old literature, there is a group earlier on called what is the name? Pandolfino. They would actually create a pneumothorax or divide a vagus nerve deliberately to lengthen the esophagus, and nothing used to happen to the patient. Motility is concerned. Except that one patient where I've done a thoracoscopy, I have never placed a intercostal drain for a pneumothorax when I'm injuring the left pleura, and I open the left pleura at least once a month. I do 6 to 7 fundos a month, and at least one I open the left pleura. I just ensure that there is good PEEP given, there is no mediastinal emphysema, and the saturations are maintained. I don't even do a post-op chest X-ray. The worry is the next thing: post-op dysphagia, gas bloat, and patient symptoms. So when would you avoid a surgery? The bottom rule is, if your symptoms are not responding to PPI, there is no anatomically demonstrated abnormality. If there is an intractable esophagitis which is not responding to PPI, if your LES pressures are normal, if you have a stricture, if you have a severe gas bloat pre-op, be very, very careful, because this patient is not going to be happy post-op. So I've shown you the various patterns of failure that we have seen. We have discussed the diagnostic workup, which means upper GI endoscopy, imaging with a CT scan, and manometry. I have told you which patients do well with redo surgery, what not to do of a redo surgery. I've also told you some technical tips, what we do intraoperatively, and I'll be happy to answer any questions you have at the end of this.
Thank you.
Thanks, Roy.
Thank you, Prashant.
Thank you. It was a fantastic, mesmerizing lecture. I have few questions. If
Yes,
the
Prashant.
crura is not approximating, do
Yes,
you give
yes.
releasing in?
Yes, I have done release incisions about 3 or 4 patients. So what is Prashant mean?
And where exactly and how exactly that?
No problem. So two choices. What I have now in the last 5 years been doing is Yogesh, can you hear me?
Yes, sir. Yes, sir.
Hello?
Sir,
Yogesh,
there
I
is a
suggest
voice
to
problem.
webcam band karo tap.
बंद
तो
करून
webcam band
टाकतो,
karo
sir.
tap. Let's keep an audio.
Yeah. We are
So
listening to you clearly with webcam off. Now talk, sir. Yeah.
the audio is clear now?
Yeah. Yes, sir. Go ahead, please.
Very good. So what I used to do, I think until
Yes,
about 2016, is make 2 kinds of release incisions. What I initially started doing after I attended a seminar in ACG in Las Vegas was we used to split the right crust vertically and slide the right crust towards the left and close it and deploy a mesh to cover the defect in the right crust. But what I realized is behind the crura is the IVC. Sometimes you have the left hepatic vein that comes at the apex of the right crura. So I've given up doing this. Now I will make a vertical incision about 5 centimeters lateral to the left crust vertically. Close the crura after sliding it and then put a composite mesh over that. But I've stopped doing it for last 4 years, since 2016. Since 2016, what I'm doing is, if my intercrural distance is more than 5 centimeters, or the hiatal pillars are not good, they're not strong, not holding my sutures, they're splitting on table, I'm very happy to put either a composite mesh or a biological mesh. Now, the biological meshes that we get in India are the Wilson Hook Surgisis porcine meshes, and these have a high recurrence rate. So currently, of what we have in India, I use a composite mesh. There is a mesh available in the US made by Bard called a Phasix mesh. This is a delayed absorbable mesh, and this absorbing of this Phasix A occurs at 18 months. To me, that is the best mesh to use either for a diaphragmatic defect or to use for a crural closure. This is corroborated by a study published in Surgical Endoscopy in 2006 by Dr. Chowdhury's group, looking at 40 patients who use meshes. Their criteria was the same as what we do: elderly patient, paraesophageal hernia, poor crural pillars, or intercrural distance more than 5 centimeters, put a composite mesh.
How do you treat stricture above the hiatus?
So what Prashant is asking me is
Hello.
peptic stricture. Can you hear me? Prashant, are you with me?
Yeah.
Yeah. So what Prashant is asking me is a question about peptic stricture of the esophagus. Now, how do you first make sure that this is a peptic stricture and not a malignancy? You will first do a narrowband imaging. You will do a chroma endoscopy. You will take multiple biopsies. These strictures will be within a few centimeters of the OG junction. So my rule is dilate the stricture, Give him high dose, double dose PPI, pantoprazole 40 BID before meals for 6 weeks. Redo the endoscopy. If the endoscopy shows a stricture still in place, I will inject Canacort 4 quadrant. If the stricture recurs, I deploy a absorbable vicryl stent into this. If the stricture remains open at 6 weeks, I will do anti-reflux surgery for this patient. Prashant?
Okay, yeah, got it. And what is your protocol to treat and how or manage the tight trap?
The tight wrap, basically it's tight. There are two issues. One is tight crural closure and one is tight wrap. If with a tight crural closure, as demonstrated by an endoscopy, because it hugs it's like a pseudo achalasia. You get a narrowing and you get a resistance and a give like you get in achalasia. If it's a tight intercrural closure, I will do a TTS balloon dilatation, keeping the balloon open for 3 to 4 minutes. I explain to the patient that your dysphagia will go, but you may get a little bit of reflux if the balloon dilates the crura too much. Most times when you have a tight wrap, you need to laparoscopically undo the wrap and redo a partial fundoplication. Prashant.
Okay, okay. Are there any questions from the audience?
Tome sir, you are
Hello,
online,
Roy.
sir?
Yeah.
Good evening, Dr. Tome. Good evening.
Good evening, Roy. Pleasure listening to you as usual.
Pleasure
A
is
great
mine. Thank you for
experience.
having me. Thank you.
A great experience on your part, and good that you shared all that today. I just have one question. I don't do a lot of this surgery. Whenever I did open. I have been taught open surgery and not laparoscopic.
Yes, sir.
In this, if I have heard you correctly, you do a crural repair and then put a onlay mesh on that. Is it so?
Yes, sir. So there are two ways we can do it. If your crura is coming together easily, you close the crura and then put a mesh on top of that. If, like Prashant asked me a question, very wide defect, 7-8 centimeter defect, the crura can't be closed completely, then I will take a darning stitch from crura to crura like a darn, creating a bed for the mesh and then place the mesh on top of that. Because otherwise,
you never do it tensionless like Lichtenstein, which we do.
Sir, most of our anti-reflux surgery is tensionless, but we are only talking of patients where the defect is so big that you can't do it without tension.
No, your worry is that the mesh itself will get migrated into the mediastinum, isn't it?
Yes, sir. The mesh will go into the posterior, it floats into the mediastinum and the fundus goes with it. So it creates what is called a radiological recurrence.
That's right. That's why you need to have it nearly tight and not allowing the mesh to go into the mediastinum. Is it so?
Yeah, absolutely.
Hello. Okay. Thank you so much.
Yes, sir. Yes, sir.
Thank you. Thank you for your wonderful lecture. Thanks.
Thank you, sir.
Some more questions from the attendees.
आपल्या व्यतिरिक्त कोण आहे का प्रश्न? कापडात आहे सगळं.
नाही सध्या 53 लोक आहेत सध्या. सध्या 53 लोक आहेत.
Great.
Roy, one more thing which I want to share.
Yes.
I don't know, but I don't see too many patients of reflux in my practice.
So you're a cancer GI surgeon, that's why you don't see them. But most
Maybe
of these patients remain with medical gastroenterologists who don't refer them to you. I think over the years we started our manometry lab in 2007, and we do almost 10 manometries and pH studies every week. So in the West, we have got a fairly good reputation. We get a lot of patients referred to us, both primary and for recurrent symptoms. So I think you need to have an interest in this. And once you start doing large volumes, automatically the GI physicians start sending you patients.
That's
so I think these are patients who they need to be referred to you by gastroenterologists. They don't come from your OPD.
Yeah. And I agree with you that it is the volume refluxes which get most benefited.
Yes, sir.
And patient selection remains one of the most important key, and that comes with experience probably. That you don't need to touch each and every patient of reflux.
So you need some gray hair, or in some cases no hair, to get that.
Very right. very right, because I get a lot of patients who have been advised anti-reflux operation, and when they come to me, I find that probably these are the patients who don't require operation.
So, and those patients usually do the worst because they tend to develop new symptoms and they'll eat your brains post-op.
That's right. And do you agree that most of the patient can be managed with medical management?
I don't agree at all. I think PPIs given long
No,
term have their
in
own
a
set of
spectrum
problems.
of 100 patients you have, how many in general, 100 patients of reflux disease, how many would require surgery?
2 or 3.
That's right.
97%. Sir, problem is patients coming to me usually have taken PPIs for several years. They have been had one surgery and then they come to me. But if you see a general practice, I think 97 or 98% with lifestyle changes and PPIs get well. We must emphasize
That's
to the patient that long-term PPIs do have their own set of problems, and we must make the patient aware of that. So if you have a young anti-volume refluxer who's taking PPIs for 5 years, you need to at least make him go on the ACG site and show him what the complications potentially are, and then let him decide.
yeah, agreed. Agreed.
Sushil Lohia, you are there. You just unmute your mic and then you can ask the question. Sushil, he's not there. I think Abhishek Katakwar, I have
Sir,
unmuted your mic. Yeah, please go
Can
ahead.
you hear me?
Yes, Abhishek, we can hear you.
Yes. Yeah, good.
Hi, Dr. Roy. This is Dr. Abhishek from IIT Hyderabad. I had 3 questions which seem important to me if moderator allows. One is, what is your opinion about sleeve fundoplication? I haven't done any in my life, but I have been reading and hearing about it. That's my first question. Second question is, what is your opinion about poem fundoplication? I know it's a controversial question. Being at AIG, a lot of endoscopists do it here, but I have no clue how it's going to do in long term. The second is more like a comment. When I do sleeve gastrectomy and I do all endoscopies myself preoperatively, and if I don't find any, GERD or any kind of migration or everything is normal. But when I do sleeve gastrectomy and if I find a lot of fat near the left crust, then what I do is I ask my anesthetist to put the bougie completely inside, fill the bougie bulb with around 30 cc of normal saline, and then I try to, I ask them to pull it slowly backward. If that bougie crosses the G junction, it means that patient has some kind of laxity there, and then I try to look for the any kind of hiatus hernia. What is your opinion on that and the previous 2 ones?
We'll start with the third one. We have a very short-term memory. We'll start with the third question. I am not aware of any data or published literature that shows that you can inflate a bougie and pull it back to quantitate a LES size. To me, the patient's symptoms and the preoperative endoscopy are supreme. If the pre-op endoscopy was normal and the patient had no GERD, I would not test the laxity of the GA junction. I would do a sleeve gastrectomy after denuding the fat like you normally do. Question number 2 is poem fundo. Now, for years together, I have been hearing the AIG group telling me that the poem never caused reflux. The poem had complete relief of dysphagia. The quality of life was wonderful. GV Rao tells me in the last 5 years, they have not done a single Heller's myotomy. So all patients are getting poem, and whenever I have debated Nagi or his team, they would always say the dysphagia is fantastic and they never get reflux. Their publications also say that reflux is less than 5%. The question I want to ask Abhishek is, why, Abhishek, suddenly you guys have started doing poem fundo? You never had reflux. Why are you now doing a transoral incisionless fundo, which adds more than... No, let me finish. I heard you out. Listen to what I'm saying. You are doing a poem and then doing a transoral incisionless fundoplication, doing fill thickness suturing, a technique which is not validated, which should be done only as part of a a trial.
You are not audible
So
now.
this is my first question. I'm not audible, Prashant, you heard that? Hello?
Yes, you're audible.
Hello?
You are a bit inaudible.
So years together,
you can, yeah.
I'll
Please go ahead.
speak
Please
again.
go ahead.
I'll repeat. So for years, Abhishek, the AIG group told us the poem had 100% relief of dysphagia and the reflux was less than 5%. And suddenly we find that you are now doing poems and you're doing transoral endoscopy and fundoplication, which adds almost more than ₹1,00,000 to the cost. It is not meant for patients with large hiatus hernias. So this first raises my hackles. For 5 years, when we debated you've seen your publications, AIG told us you never had reflux. And now suddenly AIG tells us you're now needing to do a fundoplication with most patients of poem. So this, to me, it doesn't sound very logical. And I have told this openly to Nagi also. In the interim period, Nagi, sorry?
We are on the same page. I am on your side.
Great. So in between, in 2018, Nagi started doing ARMS, mucosectomies. That he gave up, and quietly now they're doing transoral incisional fundoplication. The first question was about doing sleeve fundoplication. Now, I believe that the sleeve is a refluxogenic operation. And I think merely putting 1 or 2 sutures to close the crura and add a fundoplication does not make a sleeve safe to prevent reflux. If a patient is symptomatic for GERD, he has a hiatus hernia, please don't do sleeves with or without fundoplication, just do a rheumogastric bypass. Prashant.
Okay. Thank you.
Yeah. Rajendra Sauji sir, are you there? You want to ask some question? Please unmute your mic. Dr. Rajendra Sauji, I have unmuted you. Okay. I think he's not there. Dr. Mukund Thakur, you can unmute your mic. Hello. Yeah, Mukund.
Yes.
Mukund, you are there? Okay, I think today network problem is quite a lot. Anybody wants to ask question? Yeah. Too many webinars going on, I think, all over. Sushil Lohia, are you available there? Sushil, I have unmuted you. Sushil Lohia. Okay. So.
Hello.
Yes.
Hello.
Yes, go ahead.
राठे
Go
सर.
ahead.
Yes.
Go ahead.
संजय घाटे बोलतो. Hello.
हाँ संजय.
घाटे सर नमस्कार.
हाँ संजय. Good luck. Sanjay, you have to unmute your mic. You have muted it. Yeah. You unmute it, Sanjay.
Hello.
So I think we will end up this session.
Definitely.
Hello.
Yes, Prashant.
Yeah, Dr. Roy, it was very nice. Yeah, very big thank you for joining us, and you made a lot of fundas clear in this fundo. Thank you so much. Thank you so much.
Thank you, Prashant, for having me. Pleasure being with you.
Thank you, sir. Thank you. You can unmute on your side.
हॅलो हॅलो
हॅलो.
रहाटे सर. सर काय
हा.
झालं सर, डिस्कनेक्ट झाले का?
हो झालं. मी हे केलं कारण बरेच जण काही क्वेश्चन्स नव्हते.
सर इकडे ठीक आहे, नो इश्यू. चला, मला वाटलं की सर डिस्कनेक्ट झाले की काय. ओके, सेशन हॅज फिनिश्ड.
ठीक आहे. नाही, नाही. Yes.
नो इश्यू. चलो सर, ठीक आहे, राईट.